Having spent the first hour talking about the role of the mind and emotions in maintaining pain, I'm just going to ignore all that and talking to Barbara. Okay. No, I'll bring it in at the right time in the right way. Okay. But what I want to do is sort of demonstrate in a somewhat abbreviated form exactly how I would work with a patient who comes in complaining of some chronic neck and shoulder pain. And I'm going to do a very brief history, which is mostly going to be to identify and rule out or assess any kinds of anything in the presentation that concerns me that this is going to be something that potentially requires more care than I can offer and warrants a referral to an outside provider of some sort, including screening for any true medical emergencies, which presumably is not present. She looks pretty healthy. But that's an important principle. Now, in California, we're licensed as primary care professionals, and my understanding from talking to Aubrey last night is that in Virginia, it's not explicitly in your scope. On the other hand, patients can come to see you directly without prior diagnosis or referral from a physician. So it's essentially the same as we are in California. And that's a very weighty responsibility, isn't it? You know, that means we have to be able to differentiate between a painful but essentially benign neck and shoulder condition for which she's at no risk of death or, you know, premature disability, versus one where there is some risk, or maybe great risk. And even though acupuncture may work very well, may work better than anything else to treat it, I want to have some other people on board on the team just in case it doesn't work or doesn't work fast enough and well enough within the time frame that's needed to prevent things from going wrong. And that's a really important thing for our profession to be able to do, and I think that's one of the ways in which we, maintain and expand our scope of practice is looking at the patient through that lens of what a former teacher of mine used to say: what will kill the patient first? Is there something present that really presents a high level of risk? And with dealing with patients on chronic opioids, one of those might be opioid overdosage. I had a patient start to go into respiratory failure in my clinic from a self-administered opioid overdosage. It was not the first time he'd done it. So I want to screen for my red flags, and I want to get enough of a sense of the mechanical parts of what's going on that I can do some very prompt treatment, and that the patient will walk out feeling that there's a difference, something has shifted, something has changed. I also, of course, want to establish a rapport with the patient, a therapeutic rapport, which includes everything from informed consent, that they understand what the risks, side effects, et cetera are. They understand the alternatives to the care that I can provide. We have some conversation about the costs. I won't include that in this demo right now, but working with another patient, we want to have patients make a fully informed consent to whatever treatment we're going to administer, and sort of what to expect, how to manage whatever reactions or symptoms they may have post-treatment. Ideally, I would like to send them home with some kind of a self-care program or protocol, even if it's just one simple exercise or one simple breathing technique, something that gets them out of the passive, please fix me, I'm broken, to, oh, there's things I can do on my own to take care of this. And many of our patients are already oriented towards that, but sometimes they aren't. And that's one of the first things we have to do, is establish right from the get-go that this will only work if we're working together as a team. I'm not God. I can't just touch some place and make the pain go away forever. But if we're willing to work together, we can get somewhere. Okay. So those are some of my priorities for that initial patient encounter. So for Barbara, I'd ask for a volunteer who has some combination of neck and/or shoulder pain. So tell us what your chief complaint is and where you feel your symptoms.
My chief complaint is neck pain. It's chronic. It's more left than center or right. Kind of like right below the occiput, comes down across the top of the scapular spine. More medial if it goes down further to the scapula. And then the neck pain itself is a combination of dull and sharp pains depending on the time of the day, what I do in terms of movement, and the pain that I have that's more medial to the scapula is a very heavy stuck feeling. Like no matter what I do, it just clicks and it's just there.
Okay, very good. So that's actually most of what I need to know right there. I don't need a whole lot more, a whole lot else. I'm not going to ask for a 0 to 10 pain scale rating. I do want to know, of course, when and how did the pain begin?
My neck pain began 20 years ago due to a car accident.
Okay. And then I'll ask my magic question, and how does this, the injury that you experienced then affect your life today?
It doesn't, I just live with the pain.
Okay. I'm going to guess you'd rather live without the pain.
Of course.
Or with less pain, right?
Yeah.
Okay. But that tells me a lot right there, that she is not functionally impaired. So that's a good place to start from, in that sense, that she's not saying I can't sleep at night, or have difficulty working during the day. But maybe if I start to talk about this stuff, she might actually, well, actually, I can't see her face. You can't.
Oh. Are you asking me to talk about it?
So yeah. So does it affect your sleep at night?
Every night.
Every night. Okay. So that's actually a really important question. So sleep is a functional capacity. I always ask that question of my patients, and that is how I gauge severity, basically. If it's affecting sleep at night, it's very likely, and it's probably intrusive during the day too, as well. And of course we all need sleep for all kinds of things to function during the day. So there's a whole other class, of course, seminar, doctorate program you could do on sleep. But I want to do something to help her sleep at night. Okay. So, is there anything else when you think about activities of daily living, work, school, family roles, hobbies, exercise, travel, social life?
I mean, carrying things on this side is limited. So I would say, going to the grocery store, if you have a lot of grab bags.
Okay.
I don't have the same capacity to do it on the left as I do on the right.
So then a related question is, are you left or right hand dominant?
Right.
Right hand dominant, okay. So one of the things I'm going to look at here is normally the dominant side, I'm going to call this a shoulder, but it's not, of course. It's really the upper trapezius, the slope of the upper trapezius and the shoulder girdle are elevated on the non-dominant side and dropped on the dominant side. So I don't know if you probably can't see from the rear, but when I look at her, it's actually elevated on the dominant side, which is not normal. So that tells me that this upper trapezius on this side, even though the symptoms are on this side, there's probably some trouble here as well. That upper trapezius and the levator scapula, those are the two primary muscles that elevate the shoulder blade, are hypertonic on this side. Okay. Okay. So another location question that I want to ask, a very important one, is do you have any pain, numbness, or tingling that radiates into either arm?
Yeah, occasionally.
Occasionally. Okay. Okay. Here's my next question. That's a very common response, is like, yes, or occasionally, or intermittently, or something. So here's what I really want to know is, when was the last time you felt that? How recently? Very specifically. Days, weeks, months, minutes, days, several days ago? Okay. And how long do those episodes last for?
It varies as well. It could last for a few minutes. Yeah, I would say that.
A few minutes? Okay. And do they just go away on their own, or do you do something specific to make them go away?
I move my arm and neck and stretch.
Okay, all right. So she has some capacity to manage her symptoms in a therapeutic way, and she's not getting constant signaling down the arm. Now, some of you are probably thinking already or have an idea what I'm driving at. What I'm trying to assess here is, do we have a problem with the spinal cord or the spinal nerve roots, or the brachial, spinal cord being the centric core, spinal nerve roots coming out of the side of the neck, bundling together into a brachial plexus that supplies the arm, and then peripheral nerves in the arm. Those are the four basic divisions that I'm thinking about in terms of, so this is probably, I should ask this question, what seems to provoke those episodes of left arm symptoms? Anything particular that you can identify?
Sleeping on a certain side, like sleeping with my neck bent.
Sleeping with your neck
to the right.
To the right. Okay, so right rotation of her cervical spine tends to provoke these symptoms. Okay, that's useful diagnostic information too. That tells me that it's something about the stretching of the nerve roots on this side. That's actually somewhat uncommon or atypical. Much more common would be for the left arm symptoms to be provoked by turning to the left side, which squeezes down the what are called the neuroforamina, the little holes in between each segment of the cervical spine through which the nerve roots exit. This is one of my favorite teaching and study tools, and if you don't have a skeleton model in your office, I'm going to suggest that is one of the best $60 investments you can make. Is a little Mr. Boney. It's called, that's his name, about this high, stands in your desktop. Great educational tool for your patients, for showing them stuff, for showing that you understand anatomy and not just how to adjust their emotions and their subtle body and stuff. That's very important too. I'm not discounting it, but it really helps our patients understand their own anatomy. And 3D works better than color plates or online apps. Okay, of course you can shell out $2,000 for a full life skeleton. Who should we thank for this skeleton? It's a local school.
Virginia University of Integrative Medicine.
Oh, okay, one of our sponsors.
Yeah.
Well, thank you very much for Virginia University of Integrative Medicine. This is a great quality. I've never seen one like this actually. That's got the muscle attachments on one half of the body and the ligaments that usually get forgotten about and left out on the other half. That's really great teaching tool. And so, so those are the four, the nerve roots that exit out, the spinal cord in the middle, the nerve roots that exit out of the side. Come up and take a look at this guy in your break time. He's got quite a history of trauma, or she's history of trauma to the cervical spine. There's some segments that are badly displaced where the nerve roots are in the wrong position, but you can kind of get an idea comparing this with your anatomy plate or your apps and stuff. We have the brachial plexus, which is a big bundle of these nerve roots that forms, they all bundle together about here, and then dive through or between a couple of the scalene muscles on the side of the neck, underneath the clavicle, and underneath the tendon of the pec minor muscle, the small pectoral muscle that's underneath the big pec major on the surface. Pec minor goes from the rib cage to this little bony projection here, and it's an accessory muscle of respiration. Tight or labored or forceful breathing, we tend to use the pec minor. So it can get that brachial plexus before it branches out into the peripheral nerves of the arm, can get squeezed in the scalenes or the pec minor, causing numbness and tingling and sometimes pain in the arm of a sort that is can be almost subclinical, mostly related to anxiety, stress, and posture, right? So if the patient is doing this all the time, shallow, tense breathing or deep, hyperventilation while they're in this stressed out, hunched up posture, working on computer, doing acupuncture, eating, driving, watching TV, etc., that brachial plexus then can get irritated and pinched underneath the clavicle, between the scalenes, then where it exits underneath the clavicle, and then by the pec minor tendon here. But that will typically present with diffuse, widespread, not terribly painful numbness and tingling, like the whole arm or the whole hand at least, or just the fingertips, but all 5 fingers equally will feel kind of numb, dull, like they're in cotton wool, and tingly. Versus a nerve root, if it's just a single nerve root exiting out of the cervical spine, that path that the nerve root follows to supply motor and sensory function in the arm, that's where it's going to it's going to be much more linear and along a certain pathway, and some of them correspond fairly well to our acupuncture channels or pathways or meridians. Okay, so that's going to be my next question. This is a long way of saying, I always ask, with any kind of spine pain, neck or low back, do you have pain, numbness, or tingling in a limb, okay, in an arm? And if so, where exactly do you feel it? Is it all 5 fingers equally? Does it reach the hand, first of all? How far down the arm does it go? Little finger, okay. And the other fingers are okay. Okay. Do you feel it anywhere between your little finger and your neck? Do you feel it along your arm?
Very, very seldom.
Very seldom.
But if so, it would be right here.
In the upper arm. Okay. Okay. When was the last time you felt that in the upper arm? How recently? Weeks. Okay. Okay. So I haven't ruled out all the possibilities here because the little finger, there's a couple possibilities that suggest that. That's probably not a cervical nerve root. Does anyone know what the outside of the little finger that she's pointing to, which nerve root that's supplied by? Yeah, C8 or T1, there's some overlap. We always have to account for anatomic variation too. It's probably C8 or T1. those segments of the cervical spine are very rarely injured. They're fairly stable. Once we get to the thoracic spine, we have the ribs that stabilize everything. And most of our problems in the cervical spine come from higher up, particularly C5, C6, which is the most mobile segment. So the downside of mobility is vulnerability. Okay, and it's a very important concept, particularly for your yogini and yoga patients, right? Who just think that stretching is the cure for everything. I go to yoga classes. Yoga is great. Stretching can be very useful, can be very injurious. It's a double-edged sword. And hypermobility, actually, particularly in the shoulder, but it's also in the neck, means that things are shifting around and unstable and can sometimes impinge upon a nerve root and then come back off. And so C5, C6, C4, C5, C3, C4, the mid segments of the cervical spine, that's where most of those mobility problems are. Yeah, and sometimes all the way up at the atlanto-occipital joint, or C1, C2 segments and stuff. But those go to a different part of the hand. I've got a dermatome map in the slides, so you can reference it, easy to find online. Dermatome, so everyone knows, right, dermatome is sensory, myotome is motor. Right? Dermatome is skin, myotome is muscles. So if she's saying side of the little finger here, this is making me think more about, rather than C8T1, possibly peripheral nerve entrapment. It's also the ulnar nerve that separates from the main brachial neurovascular bundle in the upper arm and branches out and supplies what looks kind of like the Shaoyin, or the heart, and the Taiyang, the small intestine channels or pathways in the arm. Okay. So that's one thing I'm going to check for right now by a couple simple and quick tests. A nerve, you should be able to tap over it, you should be able to squeeze on it without provoking symptoms if it's uninjured. But if it's inflamed, irritated, swollen, or injured, it's going to be more vulnerable to minor provocation. She'll get a signal out of it. So if I tap here at your cubital tunnel, or that ulnar nerve, right, the funny bone that you hate to hit on something, that's what it feels. It feels like in a patient who has ulnar neuritis simply by light tapping here. Anything? No? Okay. How about if I squeeze here? So tapping is called a Tinel sign. You'll see that in the literature, T-I-N-E-L. And the squeezing is just, manual compression of the ulnar nerve. We getting anything in the hand?
No, none.
No? Okay.
I mean, a little bit, actually.
A little bit?
A little
Okay.
bit.
Well, let's compare it to the opposite side. And that's a very important principle in this orthopedic treatment of somatic pain, is comparing left and right sides. Okay? If something is bilaterally symmetrical, there's two things that I think about. One is the spinal cord, and the other is the rest of the central nervous system, meaning the brain. Okay, so, or some systemic factor, immunologic, rheumatologic, etc. But mechanical, somatic pain and injuries typically present as either unilateral or bilateral but asymmetrical. Okay, so here on the other side, do you get numbness or tingling?
No, but it is definitely different.
It's definitely different. Okay, and I tap here. Okay, all right. So there's something different here. There's some asymmetry here down at the ulnar groove, and then the other place we can check for this is it's called the canal of Guillain. Right next to this, a small canal right next to the larger carpal tunnel. Same basic idea. Nerve goes through a very small space between the pisiform and I actually forget what the other carpal bone is. Doesn't really matter to me. There's so many little carpal bones in there, but if I press and squeeze there, you feel it in your fingertips. Okay, so she probably has some ulnar neuritis. Okay, but because it's not constant, doesn't concern me too much. If it were constant, I'm more concerned. The more constant, frequent, and severe, obviously, the more severe the condition. There's another possibility, though, which is that this is what we would call a multiple crush, where something is getting pinched up here that makes the whole pathway closer to the edge. A relatively minor disturbance or provocation that shouldn't result in any symptoms does, because that whole pathway was Chinese medicine, right? There was qi and blood stagnation, or maybe heat or something, along that entire Jing Luo or Jing Jin being the sinew meridians or tracts, is out of balance, has a pathology or problem. Okay, so what might be causing it up here? Possible it's the C8 or T1 nerve roots, but more likely it's the lower division of the brachial plexus. So I like to think of the brachial plexus as like coming out of your computer, or in a large office setting, or building or something. You have a bunch of wires that bundle together into a main cable that's all lashed together so they don't fall apart and separate. But within that cable, there's still distinct wires, right? So the brachial plexus has an upper, a middle, and a lower division, and the most commonly squeezed on or impinged division of the brachial plexus is the lower division, comprised of C8 and T1 nerve roots that goes to this area. So that's something else I'm going to check for here, is if I squeeze the brachial plexus, same basic idea as down by the elbow, I'm going to squeeze here in the scalene muscles, and most of us are going to make a face, particularly if we have any history of neck injury or pain. This is not a very comfortable area to have somebody jam their thumb into. Not dangerous, but uncomfortable. But what I really want to know is, does this increase symptoms down the arm?
Yes.
Yes. Okay. Not at all surprising to me. Okay, so we have probably a bit of a multiple crush, and I'm going to guess, given the history of motor vehicle accident, I can ask if you had any significant elbow injuries or traumas.
Well, when the accident happened.
When the accident happened. Okay, so maybe both areas got it. What happened to your elbow in the accident?
I got damage to the ulnar nerve.
Got damage to the ulnar nerve? Okay. Now, did that show up in a nerve conduction study? Or?
Yeah.
Okay. So she's actually had a very useful type of study, which I find personally much more reliable and diagnostic than MRIs, or X-rays. Those are just snapshot, a photo, right? Can you tell by a snapshot of somebody, what the rest of their life is like? Not really. Okay. I mean, something you get an idea, right? Happy, sad, whatever. Maybe it's a transitory mood. Who knows? Okay. But a nerve conduction study is a study of function, right? And that's what I'm interested in. I'm not interested in photos. I'm interested in pain because the patient's interested in pain. But what we really want to get the patient to is thinking about their function. And a nerve conduction study is one of the few studies that I'll actually recommend to a patient. It's outside my scope to order one or to do one myself. But I'll say this is a useful kind of study. If your doctor wants to do it, definitely go ahead and do it. They are uncomfortable because what they do is they stick a big needle in here, stick an electrode down there, and run a much bigger needle, much more powerful electric current than our little e-stim devices, basically a shock down the arm, and they measure how much makes it down here, how much of that signal gets transmitted, and are there any abnormalities in the waveform. And they can diagnose things like Lou Gehrig's disease and multiple sclerosis, Parkinson's, spinal cord injury, spinal nerve injury, brachial plexus injury, peripheral nerve injury, maybe no injury, right? That's all very useful data. Okay? So your nerve conduction study showed some abnormalities in the ulnar nerve and anywhere else?
C4-5.
C4-5, okay. So, right, that's right, because she mentioned having pain going down the back of her scapula. Okay, that's C4 and C5 potentially. And those concern me a little. They're painful, but they concern me less in regards to the patient's function, because those that I have rarely seen, almost never seen, a patient whose ability to elevate their scapula was damaged by a C4, C5 motor neuropathy. The C4, C5 motor nerve root was damaged to the point where they couldn't do this. Most of the problem is actually the opposite. That C4-5 is firing all the time, and it's up like this, scrunching their upper trapezius and pulling on their cervical vertebrae. Okay, but C8T1, that can progress to loss of grip strength, because 80% of our grip strength is actually in our little finger. You wouldn't think that. But try that out with a reflex hammer or a pin on somebody. So it's a little party trick. Here. So actually, let's just check this on Barbara. Okay. So I'm going to take this pin here. I'm going to ask you to grip it with all your fingers, and I'm going to stabilize your wrist. I'm going to try to pull it out. Can't move it. Stick your little finger out like that. That's where her grip strength is, right? So I want to make sure she doesn't develop an ulnar neuropathy. Well, she may have some, because I shouldn't have been able to pull it out that easy, right? Well, no, that's reverse logic. I actually haven't seen it pull out that easy, but her ulnar nerve is functioning. Okay, so she's got some pain and some abnormality that showed up in the nerve conduction study, but that ulnar nerve is still giving that little finger enough signal that makes all the difference in her grip strength. Did I just talk my way back out of a confusing paradigm? Okay. All right, y'all understand what I'm saying? Everyone with me? Okay. Okay, so her ulnar nerve is functioning. She's got grip strength, but she's got pain and some abnormal signaling coming out of C8T1 and C4 and C5. Okay. But I want to do a little more physical exam here just to assess the function of her cervical spine, which obviously took a hit in this motor vehicle accident. Okay. So we looked at it. Now, what I'd like you to do, Barbara, is maybe turn around, or maybe Aubrey come. What I want to show is she's got some subtle creases on her neck. That creases show up in our skin over areas where there's a lot of motion, essentially wear and tear. Over time, the collagen fibers get stretched out and elongate. Skin starts. Right, they show up in all the as we get old, but sometimes they can be. Yeah, it's too subtle, so you're going to have to trust me on this one. It's actually, hers are not too bad. It's actually relatively hard for me to see this. But sometimes you'll see a patient with a big horizontal fold there. Fairly, particularly older patients, is very common. And that is the line where there's a lot of wear and tear, a lot of degeneration that's taken place. Sometimes it's only on one side, and that tells you there's an asymmetric wearing, but you maybe see it on both sides. And that's a useful place to needle, because that's where the tissue is degenerated and also hypermobile at the same time. Okay, and in term, it also tells us which acupuncture channel is most effective, okay? Or is effective, not necessarily most effective, but is effective. So if I use terminology, how many of you, this is on the West Coast and on the doctor program and in a school where most of the instructors are Chinese, we learn a lot about the Taiyang, Shaoyang, Yangming, Taiyin, etc., the 6 divisions as they're called, right? Is there anyone not familiar with that terminology? Great. Okay, good. Because I think that way a lot more for orthopedics and for somatic pain is much more useful than the visceral connotation. There's nothing wrong with her bladder here. Maybe, I don't know, I haven't asked, but she could have bladder dysfunction, she could not have bladder dysfunction and have zero or negligible relationship to what's going on here. And she can have a problem here and have no problems at all with her bladder. But her Taiyang sinew tract, or Jingjin, or myofascial tract, is probably affected because of these horizontal creases. So why am I saying Taiyang? Well, first of all, they're on the posterior neck. Okay. Second, they result out of repetitive flexion and extension at the hypermobile segment. Okay. So that's what it's like taking a paper clip and you bend it back and forth, and over time it's going to heat up and weaken and then eventually fail, right? Snap, right? We've all done that as kids in elementary school, right? Right? Yeah, okay, good. Okay, you all know what I'm talking about, right? Okay, so that's a Taiyang crease there, okay? And so she has a flexion-extension dysfunction. She also told us, though, that looking over this shoulder provokes her, is it your arm symptoms primarily? Okay. So she has a Shaoyang dysfunction as well, because the motions associated with the Shaoyang Jingjin, gallbladder and Sanjiao or triple warmer, are rotation in the neck and also side bending. So rotation is turning to look over the shoulder, and side bending is looking straight ahead but tilting to the right as if trying to touch right ear to right shoulder. You can see her that's very limited. 45 degrees is normal. Don't worry, I've got some charts in the notes that show you what the normal values are. But she has, I'm just going to eyeball it, about 15 degrees. So her ability to side bend is very limited. Let's look back at your rotation and see how far she can go to the right. Roughly about 60 degrees, also fairly limited, or about less than that, maybe 50. It should be 80. Let's look turning to the left. Also similarly limited. Okay. So, and how about tilting to the left? Similarly limited. Okay. So she has fairly symmetrical limitations in range of motion. I'm going to guess this is an old problem. I think you already told us, like 20 years or so. Okay. So any significant motor vehicle accident over time is going to progressively limit range of motion. But actually I like seeing, I don't want to say this, yes and no. Bilaterally symmetrical means that there is probably more of a slow degenerative process that is symmetrical in nature rather than a persistent significant mechanical injury on one side of the neck. Does that make sense? Right? If it was really asymmetric, if she could not turn her head at all to the right and she had full normal motion to the left, so there's a significant mechanical problem on the right, which is probably amenable to treatment, but but we may be dealing with more of like a chronic degenerative process that got started here 20 years ago in the motor vehicle accident that's now affecting both sides of the spine. Remember, we saw that upper trapezius elevated on this side. So I know I'm going through this very fast and throwing out a lot of information, so I just want to pause and say, is there anything that I went through that you didn't follow and needs a little further elaboration?
I'm curious about your palpation on the plexus. Was that more of a pinch or downward pressure?
Just downward pressure, just kind of jam my thumb in there quite hard. And just explain to your patient, it's going to hurt locally, not going to injure you. What I'm really looking for is symptom down the arm.
When you said tie-on, were you talking about a hand or foot tie-on or both?
Both. Yeah. So I generally think of six jing jin rather than arm leg. Yeah. So. Okay. Any other? I saw a couple other hands go up. Okay, you're all good. This is all making sense so far. Okay. So I've done my inspection. I've seen the tie-on crease. I've done my range of motion, noted that it's bilaterally fairly limited. Actually, I didn't do flexion and extension yet. That's the tie-on motion. Okay, so let's look at that. Go ahead and bend forward, chin towards chest. So flexion is fairly well preserved. It's a little subnormal. Normal is about 50 to 60 degrees. She's getting to maybe 45 or so. But flexion is usually the last to go. Flexion is the best preserved of those motions. How about extension? Actually, her extension is okay, but is more limited. Okay, so what that tells me, so did either of those provoke symptoms down the arm?
Well, I don't know which one did it, but you know what I mean? For me, once it starts to feel a little irritated, it remains that way for a while.
Okay. So that's useful information too. So that tells me that if it was very transient, like, we did one of these little maneuvers and it flares up only while I'm got my thumb jammed in there or tapping on her elbow or had her move her neck, it's relatively, it is more a local mechanical problem, okay? I press on the scalene muscles, they're too tight. She's got cervical arthritis, she squeezes on the nerve root, something like that. She's got a bone spur or soft tissue compression at the elbow or at the wrist. But if once it gets going, it continues on for a while, that is hyperalgesia. It means the pain continues it's self-maintaining, self-perpetuating. So that means that there is some sensitization of that nerve pathway. It's just the song stuck in the head that I referred to earlier, and that's what I'll use as a layperson term. And how long that goes on tells me a lot about how long is that how severe is that neural hypersensitization. If you have the patient and you do your little ortho exam and it provokes things and they're hurting 2 days later from it, that central nervous system is highly sensitized. Because none of these ortho exams are dangerous or should provoke any pain in an uninjured body. Okay. If it only happens, while she's doing it, and then she moves her neck back, it goes away. It's really mostly just a mechanical problem. Does that make sense? Yeah. Okay. So I'll just be curious to hear as we go here. I'm going to start doing stuff that's going to change things, but that's just one thing to kind of keep track of. Is maybe you have a 20-minute history and physical exam, and you did a physical exam maneuver early on. 20 minutes later, it's still hurting. That's a highly sensitized, highly inflamed nerve pathway. Okay. So I've done my inspection. I've done my range of motion. And I've interpreted the findings from that. I've done some palpation to squeeze on various parts of the nerve pathway and also correlated that with her nerve conduction study. That's about all I need in order to get started with treatment. If I were seeing her for the first time in a non-physician-led clinic, in an outpatient clinic where maybe I didn't have access to medical records or couldn't make a quick and easy referral to the doctor in the office next door, I might want to do some additional stuff though, because basically any time I hear about or see signs of arm, limb, numbness, pain, or tingling, I want to check sensory function, I want to check reflexes, and I want to check strength. Myotome, dermatome, reflex. And here's why: because nerves don't have as good self-repair capacity as muscles and tendons or even ligaments and joint capsules, which are fairly poor in terms of their regenerative capacity. Muscles are great. Muscles are full of chi and blood. They repair each other quick. They repair themselves very quickly, sometimes without any lasting consequences. You strain a muscle, work out. 2 weeks later, you forgot it even happened. Okay, nerves are the opposite end of the spectrum. Once nerves are damaged past a certain point, they don't come back. And one thing I'm really hoping that Western medicine focuses on instead of opioids is stem cell research into neural tissue regeneration, because that offers a great deal of promise for alleviating not just pain but other kinds of disability and suffering. But after about a year of significant nerve damage, it's probably not going to ever come back better than what it was. Even 6 months, often things start to flatline around that point. So with nerves in particular, I want to know, when did it start, how long has it been going on, and I want to assess how severe it is, and that tells me how frequently we need to treat, and also do I need to make a prompt referral elsewhere to get other potential treatments involved. A lot of downsides to steroid use, but I've seen some really good things happen with epidural steroid injections. Patients whose neuropathic pain down a limb, one steroid injection gets taken away for 10 years. I mean, that's pretty good response. Don't get me wrong, I've seen some bad things too. But part of that is the skill of the physician in knowing when and how much to administer. So it's good to have some good physicians in your referral network, a good physiatrist who really knows what they're doing with a needle. And at the very least, we want to monitor the patients for rapid sensory loss, motor loss, loss of reflexes that signals they're on a fast track to permanent disability, losing motor and sensory function in their arm. And that's a place where there is a place for neurosurgery. Yes, I've made too much of my living out of train wrecks coming out of spine surgery. Terrible things happen. But again, good spine surgeons in your community, there is a place for rapid decompression of the spinal cord or the spinal nerve roots so that patient doesn't permanently lose motor and sensory function. So